Well, good afternoon, everyone, and welcome back. Thank you for rejoining us for the third and final segment of the 2021 ICES Winter Forum. I'm going to immediately turn it over to the moderator for this session, who is Dr. Laura Rosella. She is an ICES senior scientist and the director of the ICES U of T site, among many other accolades. She is a researcher who's been very involved in the research in research and modeling related to COVID-19. So over to you, Laura.
Thank you so much, Michael, for the introduction, and thank you all for hanging in there to this final session. I'm just going to share my screen and get us started. Thumbs up. Am I seeing everything okay? Are you seeing it? Great, perfect. So let's get on with it. So we've actually already touched on a lot of the issues that we're going to talk about today, but we're going to go into it in a lot more depth, and we're going to talk about data and analytics and how this intersects with addressing inequities. We're very fortunate to have the on-the-ground perspectives on how this data is being used. So I just want to frame the discussion for a couple minutes before we get going. And of course, many of you will recognize this picture. This is John Snow, the father of epidemiology, who used data very effectively in the cholera outbreak in the 1800s. It's often cited as a great example of how systematic data collection can have a difference, take the handle off the pump, start a whole era of infectious disease epidemiology. But what often is not mentioned is other aspects that are actually detailed in John Snow's work, if you read them very clearly. Those that were affected by the cholera outbreak disproportionately had many predisposing factors: poor living conditions, overwork, poor ventilation, crowding, poverty, class of certain occupations. Sounds familiar? This is over 200 years ago, and we knew that the social determinants of health really shaped the first time we actually recognize epidemics officially and use data to do so. And as we got a little more sophisticated, but not much more, we were able to document these inequities. This is a statistician that went around door to door to find out whether households were well-to-do, poor, very poor, moderate, and actually was able to document the social inequities in the 1918 pandemic. And in fact, here in Ontario, during H1N1, we used case control data to demonstrate how the social determinants of health influence severe H1N1 infection and was a main independent driver. And so very consistent pattern. Of course, all of this was framed very eloquently in the early 90s by Paul Farmer, who's an anthropologist and infectious disease specialist, who asked a seemingly simple question: what are the precise mechanisms by which these diseases, referring to emerging infections, come to have their effects in some bodies but not others? And his conclusions were clear: agricultural change, racism, colonial histories, trade, major structural factors giving rise to the social inequities that we're seeing with infectious diseases. And this is a meeting which some of you may or may not know about, but actually pandemic planning has been happening for a very long time, mostly around influenza, because it was widely thought that influenza would be the cause of the next great pandemic. And this meeting, which was held in Bellagio on social justice and influenza, was held specifically because there was recognition that there was a lot of attention being paid on morbidity, mortality, but relatively little attention paid to the ways in which the pandemic could disproportionately and negatively impact socially, economically disadvantaged groups. And they suggested a plan that should be in place as part of preparedness, not response, where we would identify and enumerate these groups, so really critical data collection, engage particular groups and representatives in the planning process, not just the response process, and that we would address the special needs of groups in the recommendations and the policies that would follow. So lastly, before we get into this, we know this is complex. This is the WHO framework on the social determinants of health. We have known unknowns, i.e. we know that major social and political factors and structural factors such as racism are a key contributor to the inequities that we're seeing in the pandemic today. but we don't necessarily know how to measure them. We struggle with how to incorporate these in our analysis. We do have some data, which has been very important to make sure that these inequities stay at the top of the policy agenda. But as Anna Greenberg mentioned, we have a lot of these at the area level and not individual level. And we're constantly struggling with issues around engagement and governance. So hopefully that frames the issues for you and gives you a sense of what we're going to talk about today. Are we addressing the inequities? How are we doing this with data and analytics? And do they make a difference on the ground and in our response? And I'm absolutely delighted that you will hear from a panel today, and we'll have a couple presentations. First, we'll hear from Jen Walker, who is the ICES Indigenous Health Lead, joined by Cara Mulder, who's Senior Health Data Analyst at Chiefs of Ontario. They will present some of the work from the Chiefs of Ontario Applied Health Research Question work that's been done at ICES, and we'll talk more about it in the panel discussion. And we'll hear from our Chief Science Officer, Astrid Guttmann, who will present a range of very rich and important analysis that ICES has been leading, trying to get at health inequities and lots of social determinants of health. And last but not least, we are very fortunate to have Liz Corson, who's a supervisor of health stats and epidemiology at Toronto Public Health, and Monali Varia, who's a manager of infection prevention control at Peel Public Health. These are the individuals leading and working tirelessly and have been working tirelessly over the past year, trying to take this data and understand how it can help the response locally. So we'll provide us really rich insight into this question today. So without further ado, I will stop sharing my screen and we'll move it right over to Jen and Carol for our first presentation.
Thanks so much, Laura. So I'm Jen Walker, and I'm kind of excited to share with you a little bit about what we've been doing at ICES to respond to the information needs of Indigenous nations in Ontario. So, early in the pandemic, and like the history of pandemics for Indigenous nations and their experience with pandemics are really linked with both the experience and the process of colonization and also the consequences of colonization. So it includes, this includes sort of factors similar to what Laura was just talking about that place Indigenous people at higher risk for both COVID-19 transmission. So things like housing conditions and crowding, and also severity, so COVID-19 severity, because Indigenous populations in general have higher rates of multiple chronic conditions that place a person at a higher risk for severe outcomes at younger ages than other people in Ontario. So at ICES, we have worked over the past decade to build strong relationships, partnerships, and data governance agreements that form a strong foundation of infrastructure for First Nations data with Chiefs of Ontario, which we'll talk about, and also Métis data with the Métis Nation of Ontario. And this infrastructure is built in ways that respects the governance and sovereignty of First Nations and the Métis Nation. And so where these things were in place, so there are certainly gaps when we look at the whole experience of all Indigenous people in Ontario, but where these things were in place, we were able to mobilize pretty quickly for our partners to get COVID testing information and regular updates on COVID-19 to those who need the information most for decision making. So uniquely for First Nations leadership, they need information regularly, timely information to make decisions for their communities and populations. Things like, mobilizing for controlling borders for First Nation communities, understanding when and how schools should be opened and closed in communities. So individual nations hold the sovereignty to make those kinds of decisions in their communities, and they need information to be able to do so. So I want to, I'll start sharing my screen now and pass off to Carol, who will talk a little bit more about the relationship we have with data, getting data to the Chiefs of Ontario and the First Nations leadership who require the information.
Thanks, Jennifer. Carol Mulder. I hope you can hear me okay. Can you nod? Yes, you can hear me okay? Yeah, all right, good. And I work, as Jennifer and Laura had mentioned, with the Chiefs of Ontario. And what I just wanted to show here, to pick up on what Jennifer was talking about, was the actual weekly reports that are released by the Chiefs of Ontario based on the data that is provided from ICES on a weekly basis. So if you want to go to the next slide. The Chiefs of Ontario, for those who might not be familiar, is a secretariat for Ontario. It's about 133 First Nation communities, and the secretariat is involved in advocacy and nation building, and works at that sort of central, regional, provincial level. So we can go to the next slide, please. What I just wanted to do is just show you a couple of the elements of the weekly report, because we're going to talk more about this report and what it means to the Chiefs of Ontario and First Nation leaders. And I just want it in the panel discussion, and I just wanted people to have a bit of a picture in mind about what we're talking about. So this particular graph is weekly, and if you go to the next slide, it shows the starting point there, and you can also see that in the title, weekly report number 43. So we, like many of us, have been doing this for a long time, and you can see also the end date there, February 7th. This is very timely data. This is last week's report. I'm actually just working on this week's report right now, and that timely aspect of the data is really crucial, because again, it's change over time that has been the most valuable element of this report as we go forward. So again, that's one element of the report, just showing the weekly number of cases. And then the next slide, please, is another element of the report, which shows positivity. And this graph, like all of the graphs on the report, compares what's happening with all of the First Nation people in Ontario versus all of the people in Ontario. And we'll talk a little bit more about that when we get into the panel discussion about inequities. But, you know, we're constantly trying to understand the context of where First Nation events are happening relative to Ontario. And you can see here that the positivity rate, and actually the number of cases among First Nations was lower, mercifully, than might have been expected based on other experiences. So I just wanted to show those few slides. I think there's one more slide, Jen, which is just, oh yeah, it's just contact information. So these reports are publicly available on the website of the Chiefs of Ontario. I will confess that it's a bit hard to navigate. So if you need to find that report, please feel free to contact me. And I'll leave it there, and we'll discuss more in the panel.
Much, Carol, for that, for those visuals, be very helpful in our discussion. So Astrid, over to you, if you want to just share your screen.
Can you see it, Laura?
Yep, looks great.
Excellent. Okay, thank you very much. And I'm really pleased to be just saying a few words really around some of the analytics. So not the deep research, and Laura's talked about how health inequities and the reasons, the underlying reasons for these inequities are very complex. But I'm going to talk more about some of the work that the ICES committee that's been in charge of the daily reports for many months related to long-term care, and that now weekly reports have been trying to do related to inequity. Sorry. And really, I think, I'm going to focus a little bit on the power of data linkage. So the ability to enhance what public health units would normally have, the case data, with some of the health administrative and demographic data. In particular, the importance of being able to look both at testing as well as positive cases, the ability to drill down to populations and some individual risk factors, and then talk a little bit about the power of the postal code. So, Laura discussed, and many have mentioned, we tend to, many of the data that we use to think about inequities are at the level of neighborhoods from census data. And those can be quite powerful, at least initially, to start, describing gaps. But it's the postal code also brings you to specific communities, and we've really been very focused on that. And I'll give a few examples. And then just, I think what comes out as well is just really the importance of, disaggregated data. So we've seen a number of, Dr. Dalla showed something as well. We've seen a lot of slides that look, unfortunately, like this. So these are data that PHO published very early in the spring in the pandemic, using postal codes of those patients with COVID-19 and linking to neighborhoods. And in particular, linking to diverse neighborhoods. And this comes out of the Ontario Marginalization Index and is one of the constructs, and it really reflects newcomers as well as those who identify as visible minorities. And very, very clear that both case numbers and per population incidence tracked very, very closely to neighborhood diversity. And our committee, in our weekly reports, we're tracking that as well. And this is just, one example. I could have put cases up. This happens to be percent positivity, where you just see this relentless increase and the gap just continuing to widen. This is in wave 2, over the fall, related to ethnically diverse neighborhoods. But by contrast, testing, so light blue here are those living in the most diverse neighborhoods, is lower, in fact. So clearly showing, a really big gap in testing, although some improvement over time. But if you think back to the difference in cases, clearly a mismatch. But then again, as I've mentioned, this postal code doesn't just give you, a quintile of something. A postal code is a place. And so we've been quite focused on, in our work, of really trying to drill down at very small area levels, both to report at the provincial level, but for weekly reports that we do for all the public health units. And these are data that we've just published, which looks at the cumulative incidence of COVID-19 through January, and by geography and by smaller areas within public health units. And of course, looking at this, it becomes very clear that there's, a very inequitable distribution of those who test positive by geography. And we know a lot about the neighborhoods where that have been the hardest hit. So we know that these are largely neighborhoods, again, with many of the things that have been discussed today. People who need to leave home to go to work, people who take public transportation to do it, who live often in relatively crowded circumstances, often with, multi-generational. And as the census data showed as well, communities that are largely Black and brown, often, but not always, lower income. And so we've really focused, in our weekly reports, very much on trying to provide data, at this level. And so this is one of our, usual reports where we rank the small areas, which are based on the first 3 characters of a postal code. And we've been doing this and reporting it publicly as well. And, again, trying to get data out to those who need it, both from both decision makers, public health units, but also, the public and media and those who take this to further advocacy as well. This is a nod to our amazing, Hannah Chung, an amazing senior epidemiologist here. And so these are bubble plots that we've done. So this is for Toronto. And what we've tried to do is really combine both all three constructs. So testing, percent positivity, which is related to cases and testing as well as cases. And what you see here is within Toronto, these large bubbles reflect large numbers of cases. Along the x-axis is testing, and along the y-axis is positivity. And so while here you see, you know, the neighborhood that has the largest per capita cases and happens to also be a neighborhood where there's a lot of testing. So that's a good thing. But you also see, you know, many neighborhoods with very few cases where there's lots of testing, and by in contrast as well, neighborhoods with high numbers of cases, high positivity, and not as much testing. And so again, just to give a sense of what we've been trying to do with some of these, you know, weekly visuals and data visualization outputs. We've also been fortunate, you know, to leverage, you know, a number of longstanding partnerships. So ICES has had a partnership with the Federal Immigration Ministry for many years, and we have individual level immigration. And so we've done a few reports now where we've linked these data to really be able to, at the individual level, better understand what's been reported at a neighborhood level. And what we've shown, and so this is over time, and these are cases over time, you know, huge differences within immigrants based on the category of immigration. And so here in light blue, so this is a group who come to Canada as economic caregivers. These are largely women, mainly from the Philippines and the Caribbean, and they come as live-in nannies, and they come to take care of the elderly, and many of them end up in healthcare. And you can see, you know, just a huge, you know, burden of COVID here during the first wave, and then again increasing. Similarly, you know, in purple we see, you know, refugees. And of course, you know, many things tied in with this. You know, Laura's talked about some of the social determinants of health. So you know, those who come as refugees also come from certain countries, often, you know, also, you know, come in with very little, very few material goods. And so there are many different sort of intersecting issues that are, you know, underlie, you know, what we've been able to describe. And then finally, just to show, you know, sort of linkages to occupational data through the public health case finding system in this same report, where we showed very clearly that of those who test positive, and this is women here, you know, about a third are healthcare workers. Disproportionately, these are immigrants and refugees coming from, you know, a few main countries. Similarly, when we looked at region of origin, you know, really reflecting now some individual level data that public health units are now collecting, you know, very clearly within immigrant groups, you know, a very high burden in immigrants who come from countries such that when they are in Canada would be considered racialized. And then we did actually drill down even to the country level, and we did this with advice from our public engagement, public advisory council, in part because of some of the links that we wanted to make to communities. And I show this to give an example that, you know, this is data, these are data that we showed at the provincial level, and showing that in fact, Somali Canadians had some of the highest percent positivities. And when we did these reports for specific public health units, the same, even though the public health units have a very different immigrant populations. So for instance, you know, Peel, that has largely a South Asian immigrant community, this held true as well. And so the more you disaggregate the data, the more, you know, you can, you know, start to better understand some of the populations at risk. But I will end with this, and I got a text this morning from one of my colleagues who was saying, you know, sometimes when we talk about data, we actually forget that we're talking about people. And I also put this up because I think it really speaks to, you know, a lot of the structural issues that Laura talked about, but that are, you know, not easily measured. And so this was a quote from Ms. Concepcion, who was interviewed by the CBC when our report came out. So she came in as an economic caregiver. She was a registered nurse in the Philippines. She is now a PSW. She also works in long-term care and unfortunately had COVID, and said, you know, job security, it's not there at times too, because a position is not permanent and there are no benefits. And so again, I think, you know, bringing this back to why this matters, but also to, you know, a lot of the complexities of trying to, you know, direct policy and programming against, you know, very complex problems. Thanks.
Great. Thank you so much, Astrid, Carol, and Jen, for really giving us some very thought-provoking data. If you could just stop sharing, Astrid, just so we can see us all. I'm going to go right into questions. There's some great questions coming in, and we have some prepared. And before we go to Liz and Monali, I'm going to just go to you first, Carol and Jen, if you have anything additional to say, because you presented us that data. I wonder if you could just say a bit more about how this data is being used to support COVID management. Jen gave some great examples. And were there data that were missing, that you were being asked by the community that was not there, and is something that we need to figure out looking forward?
So this is Carol, and I'll address sort of the regional provincial type reporting and use, and then Jen, maybe you can talk a little bit more about community level experience. So again, in keeping with Chiefs of Ontario operating as a secretariat for all of the First Nations are in Ontario, the reporting is at the regional level, so it's not at the community level, and it is shared with First Nation leadership and the public, as I mentioned, on the public website, and it's also shared with the Government of Ontario, where it appears to be well received based on the fact that we get lots of requests to share it further and more details and that sort of thing. And it's, as I mentioned before, the value is that it's in a really consistent, relatively automatable. It's not completely automated, but it's within the capabilities of the Chiefs of Ontario to be able to manage that data and turn it around very quickly. So it's been very useful from perspective. There are some gaps that we've talked about that, you know, we started off with just the COVID testing data. We are now looking to include more data about outcomes like hospitalization and deaths, and hopefully vaccination data as it becomes available, maybe data about the variants as that becomes available. But again, that's all from the regional perspective. I'll maybe let Jen talk about a community perspective.
So what this ARC, so this applied health research question that Chiefs of Ontario put in, actually has given us a bit of a framework for other community requests. So communities who want to know about their specific First Nation communities or groups of First Nation communities, if they don't have access to their own data, then it has been a bit of a framework for them to be able to. But there's 133 First Nation communities. Like, this is a massive need in terms of the kinds of reporting and information that would be helpful. So we do these weekly reports that Chiefs of Ontario take then and compile, you know, over time and things like that. But I think that really in the future, you know, some of the things we've learned is just the importance of that quick turnaround of information. As nuanced and community specific as possible. Sometimes we can't answer the questions about, you know, what could happen, you know, if schools are opened, or what might be the impact, or what could have been. So I think there's lots to learn from what we've done so far, and for sure, I think community level information as much as possible is useful in the future, because that's how decisions in First Nation communities are made. And then I should also say that I think there are still some, from some Indigenous health service organizations, there are still some gaps from their perspectives in urban settings or in other settings where there's diverse Indigenous populations that they're serving. They feel that they're not getting the kind of information quickly enough that they feel they need. So I think that the complexity as well as jurisdictional challenges that exist in the healthcare system for Indigenous populations are mirrored in the data in many cases, and so it just makes it challenging.
Yeah, that's a great point. Okay, I'm going to go to Liz and Monali, and maybe Liz, you can take this first. We've seen the provincial data and we've seen some of the high-level data. I wonder if you could give us a sense of what data you're tracking at the local health unit level to track health inequities, and a bit about how this data is being used and some specific examples.
Sure, thanks, Laura. So Toronto Public Health and other health units in the province, we collect data during our case investigations with COVID-19 clients, and this includes information on their ethno-racial identity, their income, and their household size. We also have data on COVID-19 testing rates and percent positivity for immigrant and refugee groups through an analysis that was conducted by ICES that Astrid mentioned, through linking the testing data with data from Immigration, Refugees, and Citizenship Canada. And then our third set of data to track COVID-19 inequities is our breakdown of cases and testing by neighborhood. And this comes from both our case investigations and via the testing data from ICES that Astrid mentioned. So as has been said now several times today, all of these data sources show inequities in COVID-19 incidents. Our data show that racialized groups are overrepresented in both reported COVID-19 incidents and hospitalization. And the same is true for people living in lower income households. Immigrants and refugees are also overrepresented in COVID-19 reported infections, despite their testing rates often being lower, as Astrid also mentioned. And our neighborhood data show huge disparities. I think anyone living in Toronto is aware of the overburdened Northwest community in the city, whereas some of the higher income communities have far, far lower rates. So these data have been really striking and in some cases a bit devastating, to be honest, but we have been able to put them to good use. So the City of Toronto has developed TO supports, which is the COVID-19 Equity Action Plan. And this includes targeted equity response measures to support communities hardest hit by COVID-19, both populations and regions hardest hit. So a major focus of this strategy is partnerships. So partnerships to deliver culturally appropriate, multilingual outreach and health promotion messages, food delivery and other isolation supports. And the data have allowed us to provide recommendations on areas for enhanced testing, including pop-up centers, which is also strongly relied on partnership with the healthcare system and also with community agencies. And we've also been able to use the data on these inequities to advocate to other levels of government for policy changes that have been referenced before in today's discussion so far. So paid sick leave, income supports, and eviction prevention measures, so that individuals who are sick or test positive for COVID-19 actually have that financial confidence to stay home from work. And the data have also paved the way for directing some of the emergency funding and donations that we've received directly to community partners. So we've been able to distribute funding to community agencies like DHCs, community health centers in those harder hit areas. So the people who are doing that work on the ground. And perhaps slightly less formally, but sharing the information publicly has also mobilized community groups. People who are living in these harder hit areas, I mean, they know the reality. They know why infection rates are higher in their communities. But that quantitative data helps them demonstrate that and helps them advocate for better resources through like formal, hard pieces of evidence. And in some cases, the media can contribute to that cause as well. So, approaching the media as a partner in this pandemic response, I think, can also be helpful.
Great, thank you. That's really great to hear those specific, tangible applications. I think that we're always looking at the data, we're not unsure how it's being applied. Monali, same question to you, if you could give the perspective from Peel.
Yeah, thank you, and good afternoon, everyone. So a lot of similar things to what Liz just mentioned. So we have our case level data as well. Maybe some other things that that hadn't been mentioned. So we're also looking at our outbreak level data to understand disparities, to see where we have potentially disproportionate transmission. So in Peel, as has been mentioned as an example, we've seen over 40% of our outbreaks that are associated with the manufacturing sector, for example. And then we've also used area level data to make inferences as well. As was mentioned, we use the Ontario Marginalization Index, and we're able to understand disparities related to both testing and incidents as well. In terms of maybe how we've been using the data, part of it, particularly in wave 1, has been just around understanding disparities and being able to use the information to form the basis of our COVID-19 equity and engagement plan appeal. So a couple of data examples. So like Liz was mentioning, we have seen that racialized populations, so South Asian, Black, Latino, Middle Eastern individuals in Peel make up a larger proportion of COVID-19 cases than what would be expected given their population share. We've been able to do a bit of work around analyses to understand intersectionality. So looking at race and occupation together. And so some of the things that we had found, for example, is higher proportion of particularly, oops, light went out here. In wave 1, were a higher proportion of cases among racialized groups in health occupations compared to those who were white, for example. We've also been able to do some ecologic modeling to try to get an understanding of those intersectionalities as well. Where I think, as has been mentioned, where we have been really able to dig in and use that information is, again, around the knowledge translation with different agencies. ICES data have been really helpful in terms of that testing data at an individual level. So you'll remember in wave 1 where the testing policies were changing, it really helped us interpret incidence rates. And so we've been able to use that for targeted testing, for mobile clinics in the summer. We've also been able to use some of that data for example, for ranking schools, for example, for surveillance testing as an example. And then just being able to use some of that data to reaffirm needs for example, for multilingual communications materials.
That's fantastic. Okay, and before I just go on to take some questions from the chat, I just want to stay with you both for one more moment. If you could tell me a little more detail about the engagement that you're taking with your local communities. What does that look like? We heard a little bit about the engagement with the provincial level data, but locally, I can imagine that's quite different. So if each of you can touch on how you facilitate that. Did it start with COVID or was it there from before? Would be great. And Monali, why don't you start?
Okay, sure. So yeah, in Peel, we're engaged with a few different groups where local data are in high demand to guide actions. And so early on in the pandemic, there was a regional community response table, which is a partnership of about 100 local community agencies that specifically came together to address resident needs during COVID. And so last summer, we as a health unit, we did have associations or affiliations with some of these groups, but last summer we had the opportunity to share preliminary race and occupation data and get feedback. It was interesting. So some of the lessons learned around that. So we certainly got a lot of questions about what will we as a health unit and as a health sector do differently because of our findings. And so, some learnings in terms of the push messaging. So the communities are really looking for health leadership on what our data are telling us and what general directions of action would be. But the agencies are really, because they know their communities and their populations well, they want to be able to engage in how to deliver it in the communities they serve. So, so that was something, in terms of our initial engagement. And then we have also received funding as other areas in the province around this high priority community initiative, which is really providing disproportionate areas in Peel with support around testing, wraparound supports, and community outreach. So in terms of that community engagement, we are taking the data to those tables, including the ICES data on immigrant and newcomer information, and using some of the findings from our own local context. We have a lot of household transmission. In Peel, we've got 40% of our cases are household transmission associated. So, we're hearing a lot about, what does it mean to isolate at home? Perception around isolation hotels and vaccination is coming up as well. So, so this knowledge translation is quite important.
Yeah, and the need for that at the local level. Liz, did you want to say anything about engagement that's happening locally? Did you want to add anything?
Yeah, it's pretty similar to what's happening in Peel. So we have community cluster tables, which have been convened in partnership with the United Way, and they're sort of built on existing city partnerships, but it ramped up during COVID. The tables, they represent over 140 nonprofit organizations, and they're either geography or regional based. So there's a Black Resilience table, there's an Indigenous Serving Organizations table, and a newcomer focused table, and then various geographies in the city also are represented at these cluster tables. And we've done a lot of data sharing. Astrid actually came to our newcomer cluster to present on some of the ICES data in partnership with us. And we've several, probably dozens of times we've gone and shared some of our data. And we've also asked for feedback. What did the data mean to people serving in the community and people who are representing communities that are overrepresented? And we did do a formal consultation because, like what Monali said, like a lot of the times we're presenting these data and we're being asked, okay, so what should we do now? What is your organization going to do in response to this? But I think there really needs to be a dialogue about how the data are applied and what actions actually come out of that. So we did do a formal consultation to investigate what supports needed in areas and in populations that our data showed were harder hit. And this has led to a series of recommendations that led to the EO Supports Action Plan that I mentioned earlier. So I think, the engagement and the knowledge translation really has to be a two-way dialogue.
Absolutely. So there's a question from the audience from Alan Katz, very interesting question, and I'll open it up to whoever wants to answer. So there are inherent inequities in how these data are generated. How do you address these inequities in the analyses, or how should we? Anyone want to take a stab at that one?
So I guess the question is inequities in how the data are collected. So, I mean, there's lots of ethical issues, I guess, with trying to define people based on their ethno-racial identity and fit them into, certain buckets when really there's no true categories of ethno-racial identity, right? There's a continuum. Ethnicity and race are conflated. So there's lots of difficulties there. And I think we have to acknowledge when we're preparing messaging that comes out of these data that, it is an inherently flawed process, but in trying to capture racialized populations, what we're really trying to show is the effects of racism and discrimination. And I think in our knowledge translation, if we're clear that this isn't about race, it's not about where you're from, it's about those systemic inequities that are faced by certain populations, we hope that we're helping to address some of those inequities in the data collection process and in our sort of quantification of some of these issues. I don't know if that helps at all.
Great insight. Jennifer or Carol, any insights on this question?
It's Carol from Chiefs of Ontario, and I would say that in addition to the inequities around data collection, there's also inequities around data access, and the work that the Chiefs has been able to do with Jennifer and the others at the ICES team is what I like to refer to as an overnight success that was at least 10 years in the making because of the inequities in access to data among First Nation people. So the processes that need to be in place, and Jennifer mentioned that the ARC that is in place now between the Chiefs of Ontario and ICES is actually a bit of a skeleton or a structure that communities can use to access data, because not every community, in fact, the Chiefs of Ontario, representing 133 communities, took 10 years to get to, at least 10 years, to get to a place where such an arc was possible to execute reasonably quickly. But individual communities can't do that. Like, they don't have that kind of infrastructure. So I would just, I don't have an answer to the question other than to say that it's a question of how the data are accessed and stored, that has some inherent inequities in it, as well as how the data are captured.
The one thing, Laura, I might just add just one sentence is that also I appreciate Alan's comments, because we're using data that depend on access to testing, access to healthcare, then we are also mirroring those inequities as well.
I think that's an excellent point. And what are some ways that we could overcome that? I think that's something that we're all struggling with. And the idea of triangulating data perhaps is something that we could work more towards. The idea, we get these data from these databases, and what other type of rich information can we get from other types of who's not getting access, or through mixed methods approaches that will fill out the story in a different way. Great insights. Okay, I'm going to we have a few more minutes. I'm going to shift gears and then also go back to the other questions, and just looking forward a little bit to vaccination. So as we look towards a population-wide vaccination program and thinking about priorities and who should get vaccinated as the vaccine rolls out, what are your wishes and thoughts, concerns on how data should be used to inform that process, to make sure that the vaccination programs that get rolled out, that we are not increasing health inequities or contributing to them, as we have seen in other countries that are rolling out vaccination programs right now? So I'll open it up. I'd like to hear from everyone on this, so whoever wants to start first.
I can go ahead. So definitely continuing to collect data on social determinants, and continuing to explore an equity approach to the vaccination program. We need to be able to look at population-specific data and to understand vaccine access and uptake and hesitancy, and adapt on the fly to what can be done better as we go throughout the vaccination campaign. I think that data linkages should be expanded as much as possible. We have such rich data sources available here in Ontario and in Canada, but they're often in disconnected systems. And I mean, obviously, the privacy regulations might prohibit some of those linkages from happening. Is very important, but I think we need to do what we can with our data while maintaining ethical integrity and confidentiality. And I guess another point, which has sort of been hammered home already, but we really need to do our best to provide that context when providing data on the social determinants of health. We need to talk about why people are experiencing a disproportionate impact of COVID-19 infection. Like, it's about essential work, it's about overcrowded housing, it's about no access to paid sick days, because otherwise, it's if we don't provide that messaging, then it could actually increase stigma. And obviously that's the opposite of what we really want to be doing.
Other thoughts on using data to inform the strategy? And I do want to come back to the stigma point. So thank you for raising it.
I can jump in and just echo what Liz was saying in terms of needing data to understand uptake in some of the subpopulations. We've been hearing around, like, similar to testing hesitancy, we've been hearing about vaccine hesitancy as well. And so, yeah, just thinking about how we want to be able to prioritize communities with highest risk of severity and exposure, but just really trying to understand what some of those barriers could be. And so if there are data sources around that, that would be important. And I think just the other thing is a little bit more in the weeds technical, is just the, what's really impressed upon me is how quickly we need to have access to data, to both as a as a surveillance tool, a case management tool, as well as a way to answer policy questions. So on vaccination, thinking about, can we anticipate what questions will need to be asked so that we can, structure our data in a way to be able to answer these multiple purposes.
Carol or Jen, anything to add on this?
Jen, did you want to go first?
Okay, so my comment, one of my comments is that I think that one of the ways that actually past looks at the data, so when Carol talks about this, I don't know, overnight success 10 years in the making, which I like, I'm gonna name a report that or something like that, is also that we've done quite a bit of work to look at existing levels of chronic conditions and multimorbidity that actually inform First Nations approaches to risk in the population, right? So if a 55-year-old looks like a 75-year-old outside of a First Nation community in terms of their risk profile for severity, then we should be adjusting rather than just purely age criteria for vaccination. So, some of that, some data can inform strategies that way as well.
Absolutely. Carol, I think you just want to add something to that?
No, actually,
Okay.
I think that's good.
Great, thank you. So Liz, you brought up stigma, and I want to ask it before we finish off here. Some will say, and I even alluded it into my presentation, we know these we could have predicted these inequities, and nothing is surprising. Why do we need data to make some of the really positive changes that I heard that how the data are being used to advocate for some really important needs and to make some really important policy shifts? Why do we need this data? Especially given that the data can come with risks, stigma, etc. Collecting this data is not without risk. We've all acknowledged that. So any thoughts about that? I know that that's definitely a discourse that's happening with the community and something that we are all grappling with.
I think that although within our communities, within the community of health experts and data people, we understand the pathways through which the social determinants affect health, but I don't think it's necessarily mainstream in the public opinion yet. And I think if we really want to influence policy and, even programming at a smaller level, our politicians and our decision makers really have to play a role. And to a certain extent, they're going to do what their constituents want and believe and think is right. So I think that there is still actually more work to do more broadly on educating people about the social determinants. Because there probably are still people out there who see these data and they think oh, well, I wonder what that certain person is doing wrong, in their life to whatever, right? I think that's still sort of unfortunately common thought. So I do think that the data are important and there is more to do in getting that message out there.
Great thoughts. Astrid, did you have something to add here?
Yeah, Laura, I was going to say, from the perspective of a research institute that is a data custodian and data steward, I think a lot of what we've heard here about the importance of a community engagement, that really informs, I think, how we're thinking about it. As we have a committee now thinking about race and ethnicity data and ways, to do science in an anti-racist approaches, decolonizing science. We've been, are very guided, by the work that's gone on with, Indigenous leaders and communities. And I think that's the way forward. And I think lots of people are thinking about this. And, they're for us, we hope that there's a balance of being able to, if these data are collected, use them well and with communities and in a way that, for positive change and not just for analysis.
Great point.
And I would say maybe a silver lining, is this, I think, strengthened our relationships to public health units who have these, amazing relationships with communities and, have these tables. And I think that, is fantastic. And I hope we just keep building on this and hopefully we won't be doing it won't be COVID forever, but, we know, lots of, we will continue to have health inequities, and maybe some of this will actually be, the positive way forward, for many, many different issues. So try to find a silver lining to this whole terrible thing. So.
Absolutely. Carol?
I actually was just going to pick up a little bit on what you were saying, Astrid, in that I think that it's crucial to have the data and to share the data with the people about whom the data, or who the data is describing, because it is theirs, and it's really hard to anticipate how people might use this good, right? This product called data to then go and do good things with it, right? And I think that it's maybe not necessarily we're not necessarily able to anticipate all of the things that might happen when we do this very basic element of monitoring what's happening as we're working through this process. So I do think that we can't necessarily answer the question about, why do we need all the data, except to say that we do, and people will use it, and we will be amazed at what happens with that.
Absolutely. It's a learning process. Absolutely. So we're coming to the end, and I just wanted to go back to Monali, Jen, or Liz, if you had any final comments or points you want to make.
I think this is such an important discussion, and I've certainly learned, I'm learning a lot about the community engagement piece. I wanted to, there was a comment earlier, and just thinking about other, data sources and other things that we can learn, and particularly in this pandemic, and was thinking about just pieces around, the work that ICES does with the, like the integration of different data sources. So one of the things that's kind of top of mind also is what the community agencies have been asking about is long-term effects of COVID, and that's something that I know that that ICES has access to, and so just just sharing some things that we're hearing from our own communities as well. That would be something that might inform like risk communication work as kind of the fatigue around COVID continues to grow.
Absolutely. So unfortunately, we are at the end of our time. We covered a lot of ground in that time that we had together. And one thing I can say for certain is that we won't be the same at the end of this. I think the way we will engage and use data will be actually dramatically different. And we've heard some bits and pieces of how that's happening today. And I want to sincerely thank each and every one of you for being here today, but also for the dedication that you're putting in towards tackling these health inequities. I know how hard and how much this means to each of you individually and collectively with your communities. So thank you very much for spending the time. Look forward to more discussions, and I'll now pass it over to Michael to close off the day. Thanks, everyone.
Thank you.
Thank you, Laura, and thanks to all the panelists in that last segment. That was a terrific discussion and terrific presentations. Well, listen, now it's my opportunity to wrap up. We've had a great day. We've had tremendous presentations, tremendous discussions, and we've heard how data and analytics can support the vaccine rollout, how they influenced or failed to influence critical decisions in managing the pandemic. And we learned about the role of data to both sharpen the focus on inequities and to try to figure out ways to address them. I can't say enough about how pleased I am with the content of today and the contributions of all speakers. So I want to take this opportunity to thank all of the panelists and all of the speakers across the entire day. I also want to thank all of you, the attendees. We had really tremendous attendance today, and it stayed steady really from start to finish, which is great, showing that your engagement was constant throughout the whole day, and that's not easy in a virtual event. So I appreciate that very much. I also want to thank again our sponsors, the Ministry of Health, the Ontario Sport Support Unit, and IQVIA. And I want to thank Nolan Reeds, the Director of Communications and Public Affairs, and his team at ICES who have organized this conference. the content committee of scientists and staff at ICES who helped to organize the content for today. And of course, Sally Clelford and her awesome team at Face-to-Face Events Management, who made this whole day seem so easy and seamless to those of us on this side of the screen, I guess. I want to remind you to please send your evaluation forms of the day. You will be receiving an email which will be asking you for your feedback and your evaluation, and we really do want to get those and review them and figure out ways to make these days better. And I will tell you that if you did miss anything, if you had to step away, if you missed something when someone was speaking and you want to hear it again, the entire conference has been recorded and it will be available on the Whova platform in the next day or so. And in addition, we'll be putting parts of the conference on the ICES website at some point soon. So there will be an opportunity for you to see anything you missed or anything you want to see again from today's conference. So now in closing, I'd like to once again ask Wendy Phillips to join us and end our forum with a closing prayer.
Great. Thank you, Michael. I'd like to say bonjour. Megzidó dem, a widow casa bashbon chinkas, osaxing nandunji, kiwig zibin and dunjaba, chimanmat ge parwad me and down. I'm of the Bald Eagle clan, and I'm from Wasauksing First Nation, and I'm Ojibwe, and my English name is Wendy Phillips, and I'm going to say a few words in our language first, and then I'll say some remarks as to what I was saying. So, bonjour. Chimigwach Kanagego Gajik Tot Cheki Chimigwach Mashomas Nokmas Chimigwach Dwegan Dweganak Pogan Poganak Sheshgan Sheshnak Tolkam Tolkamak Chimigwach Boaman Bomnak Chimigwach Dodem Dodamak. At this time, we give our acknowledgements to the one who has created everything and everyone. And we give our acknowledgements to what we describe as Mino Bamadzawin. And this is for us a very important concept that for many Indigenous nations across Turtle Island, we don't usually identify as a religion with creation and how to live within the laws of creation. And this means then that we strive to better ourselves, but also we strive then to attain relationships with creation and to do so in a manner that is honoring and respectful. And this means that when we do, that's when the balance and health and well-being occurs. When we don't live within those laws of creation, balance, and that's when we see the sickness. And that's when we see global pandemics like we have. So, message to us as to how we have chosen to live and how we have chosen to exist and how we have chosen to be and how we have sadly made many mistakes. So, and I know each of us, we have. And this is a time, for us to remind one another we are human. And being human, we have duties that we are to uphold. And it is to ensure the health and well-being of not only ourselves and our loved ones and our communities and the health and well-being of our future generations. And this is prophesized in many nations around the world. And this is for us, it's a time to listen. And this is a time for us to truly reflect with, like I said, with the things that we had chosen, that we now need to change how we have lived. So this is a great learning from things that they will need to change. And so we always ask, you know, when we talk about minimum months in a good way of life, that then what do we need to attain? Our perspective as a human being, we all have a spirit. And our principles that we are spiritual beings first, and then we're human beings second. So our duty then is to take care of our spiritual well-being, and then to take care of our physical well-being, and then to take care of our mental well-being. And then we talk about a concept that makes us unique as humans, and that is what we describe as. And these are characteristics and energy that no other has. And this is unique to us. These are the things that we are to take care of as an individual. And then we take care of our families. And then we can take care of our communities. And then we can take care of our nations. This is for us when we talk about, you know, when we talk about our work, and that we all need to survive, and we also need to have that what we describe as playtime. That we all need a healthy way to relax, to de-stress, and this is all new to us now. You know, as to how we did things a year ago, we haven't been done. You know, how we've been able to be able to interact with one another. That it's been a very challenging year. Excuse me. So we ask that you know, for each of you to really think about what have you learned in this time, and what you truly value. And the one thing that, you know, to think of in our decision making is the effects on the earth and us. And so any decision we make, we have to think of that. And when we make our final decision, we also have to think about, again, how has that changed, or how does that affect you're on. So for us, this is a very important concept. And I know that each of you have been more connected to your surroundings. And you have noticed, you know, how when you do spend time on the earth or go for a hike, that it does change, you know, how you feel and grounding. And this is for us, when we talk about, this is the connection to the earth, and this is what each of us needs. And so So that's one thing I would definitely encourage each of you is, you know, when you can to spend, you know, that time with her, because she is your true mother that she gives to you each day. Every gift that we receive is from her. That the water we drink, the fluids we drink are from her. And the food we eat is from her. And every breath that we take is from her. So this is for us, it's a time to truly reflect. And it is a time to really look at our human family and how we can ensure future generations will survive and be healthy and be strong. So today, you know, we have also given acknowledgements our grandmothers and our grandfathers, and we have also given acknowledgements as well to what we describe are the tools that allow us to attain a good way of life. We also ask that for everybody here, those ones who have left and those ones that couldn't be here today, that we ask for good health and long life and peace of mind. And any of those negative things that may be on your mind or on your heart, that your spirit will be lifted at this time. So when you go back, you'll go back with good energy and to feel good. So again, I would like to say a big thank you to Michael and the rest of the team, that this has been a very good day. And, you know, we ask for all these things, and that we'll be granted these things until we see each other again. Miigwech, may have a good day.
Chi miigwech, Wendy Phillips, that was terrific. Your closing prayer and your wisdom really helped to slow us down so that we can better reflect on the things we heard today. Thank you very much. Well, now it's the time to say au revoir. We will see you all, I'm sure, at the next ICES Research Forum. Have a great rest of the day and a great rest of the week. Bye for now.